important topic, that is ectopic pregnancy. Again, a very, very important topic. You are going to get one question from this area also. The most common site, so what is an ectopic? It is a pregnancy which is implanted outside the main body of the uterus. It could be most commonly found in the fallopian tube. In the fallopian tube, the widest part of the fallopian tube is the ampulla. This is where fertilization is also happening. So most common site in the tube is the ampulla. And if you want to know the incidence, ampulla, then isthmus, then infundibulum, and then the interstitial part. Now, question comes from risk factors. What are the risk factors for ectopic pregnancy? Remember, the highest risk is if there's a history of tubal surgery. Either she's had a tubal ligation or she's had a tubal recanalization. These are the two most common tubal surgeries that we do. Or there's a history of infection. So the tubal motility has been infected because of a salpingitis. That is PID. Even in genital tuberculosis and PID, this history is very common. Okay, if there's a history of a previous ectopic, that means there is an underlying reason already. That's why ectopic happened. It can happen again. She's had surgeries before, or she has endometriosis. That's why there are adhesions in the tube, around the tube, and because of these adhesions, tubal motility is again impaired. Or this woman has a history of infertility, very common. She's had IVF. In IVF, what happens? We transfer the embryo. Sometimes the embryo goes and implants itself inside the fallopian tube. Which contraceptive methods increase the risk of ectopic pregnancy? We have intrauterine devices, very important. We have progesterone only pills. Okay, so intrauterine devices and progesterone only pills are the two contraceptive methods that increase the incidence of ectopic pregnancy. Another chronic infection called SIN, salpingitis isthmica nodosa, is known to increase the risk of ectopic pregnancy, and rarely you have these congenital tubal anomalies. So the most common ones you should remember, because these comes as clues in your clinical questions. Remember IVF, tubal surgery, previous ectopic, adhesions or surgeries, endometriosis, and these contraceptives which can increase the incidence of ectopic pregnancy. Now, this is the triad of symptoms. Ectopic pregnancy has this classical triad of symptoms of pain, of amenorrhea, and of bleeding. Now, the same triad you see in abortions also, but remember this classical triad of symptoms is specifically has been described for ectopic pregnancy. So, when you have these three also in your mind, other than abortion, start thinking of ectopic pregnancy also. Now, when we have an ectopic pregnancy, what are we worried about? We're worried about several things. We are worried that if the pregnancy is in the tube, okay, what can happen? The most common thing to happen is nothing will happen. Most common thing to happen is that the tubal pregnancy will get resolved, right? It will settle by itself, okay? But the most worrying, and why this topic becomes so extensive, is that the tube is going to rupture. And if it ruptures, this patient is going to have intraperitoneal bleeding, and she can worsen very, very quickly. She can even die. So that's our most worrying concern, and that's why this topic is important. Now, if the clinical scenario, the examiner wants to ask you a ruptured ectopic clinical scenario, the symptoms and signs are going to be more severe. This patient is going to be in shock. There's going to be hypotension, tachycardia, guarding, rigidity of the abdomen. Patient is going to look pale, of course, with the classical triad of symptoms. Apart from that, there'll be even shoulder pain if there's significant hemoperitonea, pallor shock. I told you, not uterine rupture. Sorry, please correct this. This is tubal rupture. Then there'll be tenderness. Then on bimanual exam, you will find that is cervical motion tenderness. On moving the cervix, the patient is wincing. You'll find bogginess in the pouch of Douglas. That is nothing but blood which has collected behind the uterus. Okay, and then you have Cullen sign positive. This is specific, this is not specific for ruptured ectopic. This is for any intraperitoneal bleeding. You'll find that bluish discoloration around the umbilicus. And when you do a scan, but we do remember, for a ruptured ectopic, remember, is based on all this, a ruptured ectopic is a clinical diagnosis. Remember, in the exam, this is very important. If you see all this in the question, and the question asks what to do next, the answer is immediately take her for surgery and do a salpingectomy. You're not going to waste time on investigations. Remember this. But by chance, if you do an ultrasound in a ruptured ectopic, what are you going to find? You're going to find blood in the pouch of Douglas, and otherwise blood also in the peritoneal cavity. But the first place it will collect is behind the uterus. This black thing is blood. This is the uterus. It's collected behind the uterus because it's the most dependent part of the pelvis, is the pouch of Douglas. Okay, but remember, we won't routinely do this. We won't routinely do investigations. It is a clinical diagnosis and surgical management is the rule. You're not going to waste time on investigations. In the exam, please mark surgery as the option. But if the patient is in doubt, if the diagnosis is in doubt and the patient is stable, then you can probably consider doing an ultrasound. And if you don't have an ultrasound, you can do a culdocentesis, which is aspirating blood from the pouch of Douglas and seeing if blood is coming. This is only if you're in doubt. But in the exam, if the patient is mentioning, patient is in shock, you're not going to waste time. So the diagnosis is based of an ectopic pregnancy is based on the clinical symptoms and signs, which are of course more severe in ruptured ectopic. In unruptured ectopic, when the patient is stable, you're suspecting an unruptured ectopic, here there is a role of several investigations of imaging, that is ultrasound, Doppler, doing a Beta-hCG. All this is useful in an unruptured ectopic pregnancy. See, investigations play an important role in an unruptured ectopic pregnancy. So when a patient comes with a triad of symptoms and she is stable, that means amenorrhea plus pain plus bleeding. We're also thinking of abortions, right? Patient is stable. So what's the first thing you want to do? The first thing you want to do, and she's UPT positive. Amenorrhea means I'm implying that UPT is positive. What's the first thing you want to do? You want to do a transvaginal scan and look to see if it's intrauterine pregnancy. Like here, this is an intrauterine pregnancy. Look to see if it's an intrauterine pregnancy or are there signs of an ectopic pregnancy. If it's an intrauterine pregnancy, you're going to see these signs. These are all the signs of an intrauterine gestational sac. It is going to be eccentric. We are going to find the intradecidual and the double decidual and maybe the double bleb sign also. Okay, you're going to find the yolk sac and the fetal pole with cardiac activity all inside the uterus. But if it's an ectopic pregnancy, what can you find? You can either find a pseudo sac inside the uterus, which is central, okay, and it has nothing else inside it, unlike a true sac, or you find this bagel sign. Can you see this? Like a donut, this is the bagel sign. Sometimes you don't see a bagel, you just see a blob or just something lying in the adnexa. So a blob sign or a bagel sign, or you actually see the ectopic gestation outside the uterus in the area of the fallopian tube. You may even see the fetal pole, you may even see the cardiac activity. So that is of course a definitive diagnosis. You're actually seeing everything but outside the uterus. And if you switch on the Doppler on this or on this, you find this typical ring of fire sign, which is again very classically has been described for an ectopic pregnancy because of the gestational sac, the surrounding vascularity around the gestational sac. It's a very, very vascular structure. So that's ultrasound. So the first thing I'm going to do is an ultrasound if the triad comes and the patient is stable. And once the ultrasound is done, then you have a better idea what to do right next. Okay, there's also a role of doing a Beta-hCG. Now, to do a Beta-hCG, you need to understand why are we doing a Beta-hCG. There are two concepts here. One is a doubling time, one is a discriminatory zone. The doubling time basically means that in an early intrauterine pregnancy, not an ectopic, in an intrauterine early pregnancy which is growing normally, the Beta-hCG should double every 48 hours. And it's not actually double, the rise should be more than 60%. That is telling us that the intrauterine pregnancy is growing normally. So if I get a Beta-hCG done value and it comes as 500, after 48 hours, if it comes as 1000, I know this pregnancy is growing fine. Okay, and then I will call this patient for an ultrasound once the Beta-hCG has crossed the discriminatory zone. What does that mean? This is that value of Beta-hCG above which I should see an intrauterine gestational sac on ultrasound. And this value for a transvaginal scan is 1500 because we see things earlier on a TVS, And for a trans-abdominal scan, it is taken as around 6,000. Of course, as a range, some books will give 1,500 to 2,000, some books will give 5,000 to 6,000. But remember this, roughly. Okay. So this is the role of beta-hCG in ectopic pregnancy. To understand, you need to understand doubling time. You need to understand discriminatory zone. And let's look at this flowchart. So positive UPT plus pain plus bleeding. This is our triad of symptoms. What's the first thing you're going to look for in the question? Is the patient stable or unstable? If she's unstable, this is pointing towards directly a ruptured ectopic pregnancy. You're not going to waste time. You're going to directly take her up for surgery, either a laparotomy or a laparoscopy, and do a salpingectomy, remove the tube. But if this patient is stable, then it could be an abortion also. So what do? We get a transvaginal scan, see if it is an intrauterine pregnancy, okay? See if it is an ectopic pregnancy. You'll see the bagel sign, blob sign, ring of fire. So it's very clear. If you see it as intrauterine, if you see it as ectopic, you know what to do further, right? Problem kab aati hai? Problem tab aati hai when you don't see anything on the scan. And this has come as a question or twice. That UPT is positive, she's having some pain, bleeding, but you do a scan and you see nothing. Okay, that means everything looks normal, but you know there's a pregnancy there because the UPT is positive. This is called as a pregnancy of undetermined or unknown location. And herein lies the role of doing the beta-hCG doubling. So you do the beta-hCG now, serum beta-hCG, and repeat after 48 hours and see if it's doubling or not. If it's doubling, you know it is intrauterine. If it is not doubling, okay, then you start getting suspicious again for ectopic pregnancy. Okay. So again, that is the flowchart on how to approach a situation of positive UPT, bleeding and pain. Now, you know it's an ectopic pregnancy. Okay, so now we go to the flowchart of how to manage an ectopic pregnancy. So you've arrived at the diagnosis of ectopic. Again, if it is ruptured, you know you're not wasting time. You are directly taking this patient for surgery. Okay, so surgical management is the rule. In surgery for a ruptured ectopic, we do a salpingectomy. You have to remove the tube. You can't conserve a ruptured ectopic tube. But if it is unruptured, here you have the role of expectant management where we're doing nothing. We're just waiting, and because I told you most ectopics will resolve by themselves. So you're just waiting and doing weekly beta-hCGs to check if the beta-hCG is dropping or not. Or we do a medical management where we give methotrexate. Okay, or we again resort to surgery where we're doing a laparoscopy here now preferably, okay, and you're either removing the tube, salpingectomy again, or you're conserving the tube, that is doing a salpingostomy. So the same thing, okay, in a different way, this flowchart will tell you how to manage an ectopic pregnancy. Now, ruptured ectopic, I told you again, it's a clinical diagnosis, very straightforward. In your question, if it comes as a ruptured ectopic, you are doing a salpingectomy. The earlier thought was laparotomy karna because it's quicker, but the newer guidelines say you can even do a laparoscopy, whatever the surgeon is most comfortable in, and remove the tube. Okay, so that is ruptured ectopic pregnancy. Managing unruptured tubal ectopic is where the different methods are. So you can see this is a laparoscopic view of an unruptured ectopic pregnancy. What do we do in such a case? The first possibilities we allow her to be, that is expectant management. Here we are doing weekly beta-hCGs till they disappear. Okay. And it is recommended only for clinically stable asymptomatic women with a scan saying it is a diagnosis of ectopic with the following features. So you have to have these features, that is she doesn't have any pain, no pain, she's stable, beta-hCG values are less than 1000. Okay, the size of the ectopic gestational sac is less than 35 millimeter and there is no visible heartbeat. So how do you remember this? There is no pain and just add here and no heartache in giving ₹1000 and returning it in 35 days. So this is expectant management. You're not doing anything, but you do it only if these criteria, all these criteria are fulfilled. Medical management is done by giving methotrexate. How much do we give? We give intramuscular 50 milligram per meter square. Usually one dose is sufficient, but you may require to repeat a second dose if there is the fall in the beta-hCG is less. But who do we give this management to? We give it to women who are stable, okay? Women who have no significant symptoms. Maybe mild pain is there, but no significant symptoms. And the sac size is less than 3.5, and there is no visible heartbeat, and the beta-hCG here is less than 5,000. Okay. And she has no contraindications to methotrexate, and she's going to be willing for follow-up. In such a patient, you can give methotrexate 50 milligram per meter square intramuscular. Okay, so 50 milligram per meter square is given. Then how do we monitor this patient further? Because we have to still keep her under close watch. You've done a baseline beta-hCG, repeat the beta-hCG on day 4 and day 7. If the serum beta-hCG does not decline by 15% from day 4 to day 7, then you can give a second additional dose. Okay. And once the fall has started, that means it's more than 15%, then you do weekly beta-hCGs until the beta-hCG has disappeared. So this is methotrexate. Okay. Now surgical management, who do we do this for? If she's having significant symptoms, significant pain, the size is big, more than 35 millimeter, or there is visible cardiac activity, or the beta-hCG is more than 5,000. In any of these, you are directly going to do surgery. And in surgery, we can choose to either, for an unruptured ectopic, for a rupture, I told you it is removing the tube, no doubt in that. But for unruptured, we have the option of conserving the tube, that is doing a salpingostomy, that is just making a hole in the tube and evacuating the tissue. Okay, but this is done only if fertility is a concern. That means she wants to get pregnant in the future. If fertility is not a concern, that means family is complete, or ectopic has happened at the site of a previous ectopic, or ectopic has happened at the site of a previous tubal ligation. Okay, or she has a grossly distorted fallopian tube. In any of these, you're going to directly remove the tube, even if it's an unruptured ectopic. Now, just few small things about the others. Just remember the names. Ovarian ectopic is an ectopic. It's again very rare. These are the very rare types of ectopic. Ovarian ectopic means ectopic in the ovary. This is defined by something called the Spiegelberg's criteria. Abdominal ectopic is defined by the study for criteria. This is for primary abdominal. So, abdominal can be primary or secondary. Primary means that it originated in the abdomen. That means the fertilization of the embryo has happened in the abdomen. It never was in the tube. Whereas secondary is dropped down. It happened in the tube, and then maybe through a tubal abortion, what has happened? The embryo has now implanted inside the abdominal cavity. So it was primarily tubal, now it has become abdominal. Whereas primaries, it was always primarily abdominal pregnancy, and this is study for criteria. Okay. Cervical ectopic, Rubin's criteria. You don't have to remember the names, they've never been asked. This is anyway a quick revision video. Caesarean scar ectopic is something which is now coming up, so you should know how it looks like. So it is an ectopic pregnancy which is embedded in the myometrium of the previous scar of a caesarean scar. And caesarean scar, we know, is usually a lower segment caesarean scar. This is where the scar would have been given. Okay, in the lower uterine segment, that is between the body and the cervix of the uterus, and you can see the gestational sac has formed here. So anteriorly, in the lower uterine segment in the myometrium. Okay, and this is how it looks like on laparotomy. Again, if this ruptures, she will have bleeding. Intraperitoneal bleeding will happen, so it requires an emergency laparotomy or a laparoscopy. Otherwise, if it's unruptured, you can manage it medically. But if it's ruptured, then again requires surgical management. What is this? This is a Cornual pregnancy. When pregnancy has happened in the rudimentary horn of a unicornuate uterus or of a bicornuate uterus. So whenever the pregnancy is in a horn of a Mullerian anomaly, it is called a Cornual pregnancy. Okay, and Cornual pregnancy, especially in a unicornuate uterus where the other horn is a rudimentary horn, you find that this will typically present as rupture in the second trimester. Normally, tubal ectopic will rupture in the first trimester because the tube is very flimsy. Whereas in the rudimentary horn, it has more myometrial tissue around it. But when it will rupture later on in the second trimester. So if you get a clinical scenario of rupture uterus in the second trimester of pregnancy, 18 weeks, 20 weeks, 22 weeks, always think of pregnancy in a rudimentary horn. What do you do for this? You will cut off that horn. You will remove that horn. So laparotomy or laparoscopy with excision of the rudimentary horn is done. A very favorite question and a potential thing that can be asked is what is heterotopic? Heterotopic means an intrauterine plus an extrauterine. So intrauterine pregnancy plus ectopic pregnancy is heterotopic. What is the incidence? Very rare. It used to be very rare, 1 in 30,000 pregnancies, but now because of IVF, it is becoming increasingly common. So IVF is increasing the incidence. Okay, what do you do? Management. If the intrauterine pregnancy is viable, that means the cardiac activity is present and that intrauterine is growing fine, then the treatment of heterotopic is surgical. Okay, because you can't give methotrexate to this pregnancy, it's going to kill off the intrauterine one also. So if the patient is keen on continuing the intrauterine pregnancy, it is a viable normal intrauterine pregnancy, never give methotrexate, always prefer surgical management. Now, in the end, just to end ectopic, because it's so important, remember these important points to solve questions. Ruptured ectopic pregnancy is a clinical diagnosis. Surgical management is the rule. No role of beta-hCG in a ruptured ectopic pregnancy. Where is beta-hCG important? In two things. Number one, management of a pregnancy of unknown location, because we use the doubling time here, we use the discriminatory zone here. And secondly, when you diagnose an unruptured ectopic, to determine whether you're going to do expectant less than 1,000, medical less than 5,000 or surgical more than 5,000, that is dependent on the level of beta-hCG. You should know what is doubling time, you should know what is discriminatory zone, and remember the criteria for expectant, medical and surgical management of ectopic pregnancy.